talking to you from my home, comfort of my home, to the comfort of your home. So I'm Dr.
And
Suresh.
Dr. Suresh, I will just introduce you to the audience now, sir.
Okay.
This is the second of our Diabetic Food Society webinars. We have Dr. Suresh with us from Bangalore. So he did his MBBS from Bangalore Medical College, and he did his general surgical and vascular surgical training from the State University of New York, US. And he was a consultant general surgeon in Fort Myers, USA. He came back to India in 1993, and from 1999, he is the director and senior vascular surgeon at Jain. He's a senior vascular surgeon at the Jain Institute of Vascular Sciences in Bangalore. He's a diplomate of the American Board of Surgery and a fellow of the American College of Surgeons. He's one of our founder members of Diabetic Foot Society of India. He's the past secretary and president of the Vascular Society of India. He's the chief editor of Indian Journal of Vascular and Endovascular Surgery from 2017. He is also on the editorial board of Annals of Vascular Surgery. We welcome you, sir, and he is going to talk on impact and assessment of peripheral arterial disease. Sir, you can go on, sir, Dr. Suresh.
Thank you, Rajesh, for that introduction. Yeah, I'm just going to go through the peripheral arterial disease, the importance of it, how it's missed, how it's to be used, and what is the change that's taking place in arterial disease, the spectrum. So I think many of you are aware of it, many of you have heard about it. So a lot of it is basic. For some of you, it may be too basic, and some, it might be something new. So let me start. Now, you heard the previous version called CLI, critical limb ischemia, where critical limb ischemia means the patient likely to lose a leg. That's been changed for various reasons that I won't go into the details. It's called chronic limb-threatening ischemia. This is the document that came out in June of last year from the steering committee, 9 members. So I was happy to be one of them, only one from Asia. Now, this is the Bible for the lower limb ischemia, which include diabetic, non-diabetics, and all. Not burgers, it's only atherosclerotic vascular disease. So I'm going to go through some of the facts, why we're missing it, what's the importance, and how we can do better with our patients. Now, go back to Jocelyn in 34. I think anybody who is just diabetic should read that book, Menace of Diabetic Gangrene, or a chapter of that in his book. A profound statement. He said diabetic coma has fallen after the insulin came out. But the gangrene of the foot and leg have increased. And the most important statement, the last one you see in the little yellow discoloration there, gangrene is not heaven sent, but earthborn. And that is very true in India. Here it's more earthborn because it happens because of wound. So back to foot care. You put a footwear, might be too simplistic what I'm telling you. You prevent a wound, the loss of limb goes down dramatic. Jocelyn was right. Now this man, I don't know how many recognize him, he didn't like doctors at all. His name is George Bernard Shaw, the greatest drama writer next to Shakespeare in the world. He wrote a book called Dr. Dilemma. I don't want you to read it because it makes you feel very poor. He really didn't like doctors. Another profound statement that marveled the society would pay a surgeon a large sum of money to remove his leg, but doesn't pay much to save it. And that continues, unfortunately, even today in all over the world, not just in India. Now, the well-known data, which you're all familiar with, all over the world, this is from IDF, so you can go to the website and get it. You know, a huge number of diabetics, so in 2015, 415 million diabetics. And unfortunately for us, the highest increase South Asia. So we are children of lesser God maybe, so we are kind of more doomed to get diabetes and its complications. Now, if you look at the global burden of peripheral arterial disease, the meta-analysis 2010, remember it's almost a decade back, it's 24% increase in diabetic. And then it said globally there were 202 million diabetics, 67% in LMW, LMICs, low middle income countries, which includes India, obviously, and most of the Asian countries, Africa, etc. So we are more burden, PAD is more increasing in these countries rather than the high-income countries like Europe. Now, about 55 lakhs in South Asia, the 4.8 million, and 40 lakh in India, 4 lakhs annually develop CLTI, critical limb-threatening ischemia, which means, please don't forget, not just the limb loss. The life loss in these patients is quite heavy. We'll come to that in a minute. Now, in 2020, what are the numbers? These are 10-year-old numbers. Is it different? It is different, but the data is still pretty raw and not sifted through. And what is the impact of COVID? Now we know it's vessel thrombosis, one of the pathologies of COVID, as seen in the Italian lung biopsies or postmortem examinations. So we'll come to that in a minute. Now, if you look at the increase in PAD as usual without COVID, again, is very high in low-income countries, low and middle-income countries, almost twice that of the Western world. So we'll be burdened with more and more diseases. Whether it's diabetic or non-diabetic, we're going to have more PAD. PAD as a rule, even though it says arterial disease, describes the leg disease, not the total body disease. And very important is more rapid in the low-income countries, more rapid increase in middle, young patients, and in women. Women getting twice as much as the Western counterparts. Now, if you look at India, the well-advertised number is 72 million diabetics in India. Out of this, if you extrapolate the existing data, we don't have really good data from India. To extrapolate the data, 72,000 will develop critical limb-threatening ischemia annually. And only about 3/3 lower limb revascularizations are done. What happened to 70,000? We don't know. Are they there? We don't know. Now, rest of the population, look at it. This is just non-critical limb-threatening ischemia. This is just claudicants who are deceased. There'll be another 5 lakhs people. I don't know where they are. So they are missed, or are we blessed? No, we are not blessed. We know that we are deceased, not picked up. So we look at India, about 3.8 million, the 38 lakhs will have peripheral arterial disease. The limbs, lower limbs, forget the carotids, coronaries and stuff. Now, what is the burden? Let's compare the data that exists in US and Europe, which has a very small population compared to us. We just look at the yellow highlighted things. The critical limb-threatening ischemia in India is guesstimate. We don't have real figures. It's about 500,000. But USA reports 125,000. So 4 times that. Amputations, how many US? Just 60,000, most of diabetics. Our amputation, I would suspect it'll be close to about 2 lakhs per year. Now, last sentence, our low numbers may not be due to lack of disease. Maybe lack of pickup, lack of patient's awareness, lack of physician awareness. These compound the problems. And we do end up with a lot of limb and life loss. What's the impact of PAD? Everybody says chest pain, wow, you got a problem. But nobody says you got a PAD, it's a problem. Let's see the PADs, anything. One thing that we keep hearing several times in my little presentation here, the PAD, when you don't have pulses in the leg, or you have disease in the leg, it reflects the global burden of the disease. When you don't have pulse in the leg, it's universal. It's the highest indicator of any cardiovascular disease. Well written, well recognized all over the world. If you look at PAD, the atherosclerosis in coronary, carotid, renal arteries is very high. 3 times that somebody who had a coronary event to compare to the PAD. So PAD patients have 3 times that of systemic disease, systemic burden of atherosclerosis. Now, other things, very vascular specialists. One more real myth, which really hurts me most, is amputation is easier on the patient and cheaper, better option than revascularization. So there's a lot of resistance for revascularization. Not sure why. If you have a chest pain, you have something done. If you have leg pain, you want to take it off. Now, that doesn't make sense. I will explain to you why it doesn't make sense to me, at least. That's not a good statement to make when it's easier on the patient. Let's look at this Dutch epidemiological study. It's also about 10 years old. If you look at the burden of arterial disease, if you look at artery diabetics, is very small. We all know that coronaries, about 21% have disease in the coronaries. And if you just measure ankle breaking index, it's an excellent indicator of the lower limb disease. 41%, 8% diabetics have disease. If the ankle breaking index is more than 1.2, which is typical of diabetic because their arteries are so calcified, the blood pressure cuff does not compress it. So you keep getting spurious high pressures and everybody's happy. Ankle breaking index of more than 1.3 also shows there's disease. In non-DM, that's low. Let's look at leg arteries, what happens. If you look at this, if you add this, about more than 50% have disease in the leg, where only 21% have coronaries. That's the reason when you have it in the leg, you can be guaranteed these people of systemic disease. And whether symptoms in the leg or not, they need to be treated very aggressively with medical treatment, not just have surgery for leg, have medical treatment for systemic atherosclerosis. Now, amputation less risky. Keep hearing it. Oh, bypass is too risky, it doesn't work. So take the leg off, chop it off. But no, sure, I wouldn't like it, like you said. Now, compared with any surgical procedure, major amputation all over the world, well documented, they have very high morbidity and mortality. One of the highest morbidity and mortality in the world is amputation. I'm talking about this group of patients, not a diabetic or a Burgess disease, trauma or a Burgess disease, who are very good risk patients. Their rehabilitation excellent. But in these patients, is really a bad problem. If you look at this international data again, AK and BK are among the top 5 procedures, the highest perioperative mortality. So about 5 to 10% for BK, 15 to 20% AK. Very, very high mortality. Again, I need to underline one more time, this is for these high-risk patients who are diabetics under critical limb ischemia. Rates of perioperative mortality, again, is quite high. But for revascularization, is much lower than amputation. The success rate is higher, and the mortality morbidity is much lower when you do a bypass and angioplasty for leg ischemic patient. Not talking about the quality of life, that's even worse. Next to losing an eye, the worst quality of life is losing a leg. Now, is amputation cheaper? And that's what I keep hearing. No, take a leg off, it's too expensive. Have you ever thought what is the lifetime cost of these patients? I think we need to be very important for people who can live for 2-3 years. The lifetime cost for an amputee is huge. They keep going back to the hospital. Remember, 20% lose the other leg in 2 years. Or have 2 amputated on the other leg. They become disabled. So it's very high. The initial cost for a bypass and angioplasty is no question is high. Look at 3-month plus cost. It's much cheaper. Of successful revascularization. If you fail a revascularization, yes, your costs obviously go up. Now, if you take a leg off a young patient in India, especially in a country like India, where a lot of them are manual workers, you take a leg off, he can't do anything else. He can't work on a computer. He can't work from home. It's impossible. A migrant can't work from home. He needs to carry, he needs to work, he needs to build our roads, he needs to build our houses. He can't do it without a leg. Now, the devastation, we have good data in our department. When a young fellow, 50 plus, the single breadwinner loses his leg, the family gets devastated. We know that the first casualty is the female child. They stop going to school because the father is not earning. Then the male child, and the father becomes more addict because he can't work. He borrows money and smokes. So it's a perpetuating vicious cycle. Now, what is the mortality of this? Are they high? I'm sure everybody will say it's not so much. If you look at the comparative mortality, this is international data. If you look at that, pancreatic lung cancer, we all know, surgeons, others, they really haven't changed much in 40 years. Multi-billion dollars spent on them. They haven't changed. But look at the third, amputation. Why do people lose life with amputation? I mean, it's such an easy operation. 10 minutes, you can chop the leg off. Remember, every time this is from the West, where they have a good prosthesis, good material, good rehabilitation. There's a 40% increase in your cardiac workload. AK, BK. Actually, AK is higher. So if you have a 40% increase in cardiac workload, these people, 20 to 30% will end up with a cardiac event in 1 year when you have an MI, when you have an amputation. So it's not just simple. Like short parts for diabetic, for the much higher mortality morbidity than MI. The other thing we keep saying is patient comes to us late and they go to alternative medicines. I just don't believe it. At least from our data, that's incorrect. Pretty much everybody goes to an allopathic doctor. Look at this gentleman. This is our patient. Okay, he went to local government hospital, 2 to 4 weeks, and lost 12,000 rupees for toe gangrene. They went to a teaching hospital on the 6 days, few more 1,000 rupees. So-called super specialty CV hospital. I don't know what a CV is. There's no cardiovascular specialty in India. Either you're cardiac or you're vascular. You can't combine, do massive specialties. Cardiac surgeons with due respect to somebody in the audience, they cannot do vascular surgery, especially lower limb. They shouldn't be doing it. This patient went to City Hospital, then they referred to our department. By this time, we lost 3 doses of 30,000 rupees and had only 5,000 rupees left over. So we had to do for that. Patient presented late? No. Majority do not present late. I think we delayed it. Now, why is this so delayed? Delayed either PCA presentation or this thing. Thing is, leg attack doesn't really impress anybody as much as a heart attack. Though it is well known, well documented, it's equally dangerous, if not more. Now, proper diagnosis is not made. We're never taught in colleges or schools how to diagnose lower limb ischemia, how to feel for the pulses. So it's really not diagnosed. Somebody goes to the leg, they go to orthopedic, they have back pain with aortic occlusion, they put up a traction. We see a lot of these patients. Leg pain, they go to a neurologist. Nobody feels the pulse until it turns blue. Now, so incomplete examination and obviously no pulse are felt. And then everything is labeled as a TAO. It's in our genes, in our RNA, not DNA anymore. COVID is RNA. So it's in our genes to diagnose everything of Buerger's disease. There are definite criteria for Buerger's disease. I won't expound on it at this time. It's not required. So without any criteria for Buerger's disease, nothing can be done. And one thing that is severely unknown, severely underdiagnosed, is the systemic effects of somebody who's got liver limb disease. We'll come to that again. You need to realize that patient lower limb disease has a systemic disease, not just a local disease. We'll continue further. There are alternate therapies still going, aumentopexy, and then they have come down a lot, very uncommon nowadays, thankfully. The procedure performed earlier by non-vascular surgeons. With due respect to people, there are a lot of good cardiac surgeons who started this, but they did not do distal bypass very well, which we need. Bypass the leg arteries down to the foot artery, which can be done with excellent results. So, people, especially doctors, felt it doesn't work. Now, when the vascular does it, the expectation is high. So, when the heart attack patient has a bypass and fails and dies, they say, okay, it happens. The leg attack patient is failure and dies, they say, oh my God, this is a bad procedure. That's not true. They have equally high risk. The worst possible thing I can think is patient cannot afford. You need to ask yourself, can the patient afford to lose his leg, lose his livelihood, lose his quality of life? Okay, cannot afford for that time. For about 3 to 6 months, he can definitely afford it, should be done. Now, the delayed therapy is very, very common. Late referral results in patient presenting with sepsis. They come to a sepsis. Every patient we come with CLTI comes to sepsis and foot infection. Now, they need to undergo multiple procedure, toe amputation, debridement, bypass, then toe amputation again, which increases mortality and morbidity apart from the cost. This lowest chance of functional rehabilitation might be a beautiful bypass. With so much tissue loss, patient may not be still able to function. So late referral, late presentation causes this problem. The other things that happen is when they come late, we have people who come to us have a heart attack before we could do anything to them. Because major adverse cardiac events, renal dysfunction, they're all much higher in a patient who presents with sepsis, with infection foot infection. Diabetic and non-diabetic is one of the major causes of morbidity and mortality in this country. I'm sure this group recognizes it very well. Now, when it comes to septic, with the significant wound burden, the healing is long, cost is more. What happens then? Cost, apart from that, we end up with a lot of amputations because it doesn't heal well. Certain facts about PAD. I will repeat it. A third of patients with PAD do not have symptoms, except if you measure ankle break index is low. So nothing should be done about them? No, that's not true. They need very aggressive medical therapy, not for the leg, for the body, to prevent a future heart attack, to prevent a future stroke. You all are aware of the medical treatment, statin, the antiplatelets, so on. So I will leave that alone since we are aware of that. But these patients need very aggressive medical treatment. They do not need leg bypass. They do not need anything for the leg, but they need to prevent the stroke or heart attack in future. Now, repetition again. It might sound like a broken record, but presence of PAD, symptomatic or not, shows a systemic atherosclerotic burden. They need to be treated very aggressively to prevent a death from other cardiac events, not just amputation. Now, clinically asymptomatic. Now, another thing, if you're asymptomatic from PAD, you really do not have seen too many angiograms. The other extreme, nothing is done. The other extreme is when you don't have a pulse, do an angiogram. You don't do an angiogram unless you think clinically something needs to be done. Claudicants do not progress to limb loss. Other thing is claudication. There's no reason to do a claudication unless they're disabling a life or their lifestyle threat. They do not lose the limb. In India, they lose the limb because of external wound. So back to the basic diabetic foot care. To prevent a wound, you prevent a limb loss. You prevent an amputation. Now, when you have critical limb ischemia, toe gangrene, non-healing wound, you nearly always require revascularization. If you don't have pulse, of course, I'm talking about ischemic limb, not a one with the good pulses. And there's no known medical treatment for critical limb ischemia. There are all kinds of things. We use prostacyclin sometimes, but there's an adjunct or somebody who cannot do anything, no option patient. Remember, people who have claudication don't go to critical limb ischemia. So claudication should be treated conservatively because the critical limb ischemia is only 3% in claudications. But we have a problem in India. There's a rapid progression to critical limb threatening ischemia with wound or thrombosis. Two things that push patient who is a claudicant who is stable is a wound. Number one in India is wound. Thrombosis. The sudden occlusion, we have a lot of spontaneous thrombosis in India. Now the COVID is adding another spectrum to thrombosis. So you're going to see rapid progression from a stable claudicant to critical limb ischemia. So what happens when you get a foot trauma or thrombosis? It's not just simple. When you get a foot trauma or thrombosis, a claudicant, there's a loss of lumen. Let's say it's already got a 50% stenosis in the leg. Now, when you get a wound, the 50% stenosis becomes critical because you can't heal the wound. Or there's a thrombus on the 50%, it becomes a really limb-threatening ischemia. Now, COVID-19 is causing a problem. Still in the early stages. We don't know where it's going to go. We know that one of the major pathologies in COVID is endothelial damage with non-pulmonary circulation or increasing thrombosis, coronary vessels, increasing amputations. The highest amputation we had done in our department was in April. We had never done that many amputation. Granted, they could be because the patient came late, because of lockdown, transportation, just things like that. But COVID is going to cause a problem. We'll know the data maybe 6 months, 1 year down the line. Now, this is COVID. I don't think you should get overawed by this. Just showing here the two pathways for COVID. One is angiotensin pathway. Other is called a complement pathway. So don't go into detail. Both of them block various anticoagulants, antiplatelets, so cause thrombosis. These are being studied more and more and trying to figure out how to block this angiotensin, decrease in angiotensin, and increase in complement. That will come to future. Now, this is an important slide to me, very important. If you look at this here, invasive diagnostic therapeutic intervention. And look at this, there's no test, it's purely clinical. So you need to examine the patient, clinically decide patient needs something done about it, not with says. No symptoms, it doesn't matter what block you have, never justify it. Back to treating systemically to prevent future stroke and MI. Intermittent claudication, one block at 300 meters in US. Somebody walking 300 meters, depending on the age, say postman walking 300 meters is going to lose a job. He might need something done. An 80-year-old man walking 300 meters, not going to interfere with their lifestyle. Nothing needs to be done. So when you can walk that much, you should justify it. Severe claudication. Also, patient cannot work. Civil engineer, policeman, he cannot work. Sometimes justified, not always necessary. But these two, so-called stage 3 and 4, rest pain, he can't sleep, the cyanosis, rhubarb, non-healing ulcer, nearly always require intervention. No, I should say first, nearly always require first workup. So these are the clinical indications. You don't need an angiogram to diagnose this. Purely clinical exam, 15-minute clinical exam is what you're doing. Now, diagnosis PAD is so terribly watered down, and awareness for serious PAD is less. So what happens when there's awareness? The patient like this, who comes with this? Because somebody didn't spend 15 minutes examining him, they just go through the cracks. They're lost. They're gone. And they're not only lived, their life is lost. So 15 minutes or maybe 10 minutes are required to do a good, very good clinical exam. Now, you have to have 5 important aspects of diagnosis and management. I'm not going to talk about any lab. It's purely clinical. So what are the things you look at? When you complete an examination, you go for PAD, the sheet composite diagnosis and management strategies before you order any tests, clinically and history. Good old history and clinical never fails. Now, once you finish once you finish your exam, you must reach presumptive diagnosis, grade the functional severity of the patient, because the same disease can cause a different functional severity in different patients. Just like angina, somebody with triple vessel disease walking around, somebody with single vessel disease got an MI. So same thing here. So you need to grade all this during the physical exam. Now, important to recognize, not examination, so asymptomatic, functional, CLTI. We'll talk about functional in a minute. So you need to recognize these things at the end of your physical examination. Now, if you don't assess fast critical ischemia, your chance is gone. The bird has flown away. So when you assess the need, you need to assess the need for quick workup or a gradual work. So you can always do non-invasive testing. This after clinical exam, feel the pulses, do non-invasive testing like ABI. Anybody can do it. It takes 10 minutes to learn. No need for further vascular workup unless you refer to a vascular specialist. Now, rest of vascular after clinical exam and Doppler, you have it all over India, should be done only if intervention is required as evaluated by a vascular surgeon, not otherwise. Should not be doing an angiogram to see where it's less free, where the block is. No. Now, when you finish your exam, you need to come to pathological diagnosis. So, what's the pathological diagnosis? The highest is atherosclerosis. Next comes TAO, which is rare in anybody over 45 years. Vasculitis makes a very small compound. Then there's non-specific diagnosis is quite a few, but majority belong to atherosclerosis. And clinical exam, at the end of it, you should be able to say what the pathology of this patient is. But next is, now clinical findings dictate the test. I mean, you can't just keep doing test. Now, the too many tests are done without determining the clinical need for angiogram. Coronary angiogram is not indicated in peripheral artery disease. Cardiologists are very famous doing, anybody with a PAD, do a coronary angiogram. Yes, you're going to find a disease, but they don't need treatment. So unless a clinical exam dictates that patient needs intervention, you do not do any further work. Now, the problem here we have is, now, there's two extremes. One is extreme workup. Like I told you, somebody goes to leg pain or claudication, everything is done. Coronary angiogram, renal angiogram, peripheral angiogram, not required. The other end is no real workup. Somebody who's got a gangrene, they're looking at the spine, they're looking at CT, MR of the spine, but not feeling his pulses. Acute leg pain, they're not feeling the pulses. Now, we need to look at real workup. To do that, we need to do an excellent clinical exam. At the end of the exam, you need to assess the presence of possible future risk factors before you do anything on him. This called MET score, I won't go into detail, metabolic score, kidney, is it ambulatory status, quality of life, cardiac risk index. These need to be evaluated while you're examining the patient. The area is broken record, same thing again. PAD CLI, the highest indicator of future cardiac risk factors. Please remember that. You can have an MI or a stroke and die if you don't treat him well. Now, let's see the symptoms of PAD. One is asymptomatic, I talked about. The guy, you can find no pulses. In Edinburgh study, 1/3 of femoral occlusions had absolutely no symptoms at all. They're walking kilometers together. So they need nothing. And then it's functional. Functional meaning there are two. Intermittent claudication. Intermittent claudication is, you have to describe it. You know what claudication is. You walk for a certain distance. You get a pain in the muscle group in the leg. You stop, the pain goes away. That's intermittent claudication. I think all of you are aware of it. Now, we need to find out a disabling and not disabling. Like I told you before, a 300 meters or 1 kilometer may be disabling for a young manual worker, and the 300 meters not disabling for an 80-year-old man who's a sedentary lifestyle. Either way, when you have claudication, you need a minimum of good medical treatment with sinusoidal statins, walking exercises, before you decide the patient needs intervention. Any claudication, I would say 99% claudicate do not need intervention at the beginning, maybe later on. So critical limb ischemia, which means rest pain, patient cannot sleep. Rest pain is forefoot pain, not the calf pain, not the thigh pain, not the knee pain. It's in the toes and the forefoot. If you have pain, they will not let you sleep. That's ischemic pain. They need something done because that's heading towards a limb loss. Then obviously gangrene, impending tissue loss, they require intervention of some kind. Now, you have to differentiate between neurogenic claudication and venous claudications. They're not really claudications. Claudication implies there's a vascular disease or arterial disease. Now, neurogenic pain is positional. You know that lumbar spine, the first step they get a pain, they cannot bend over. Things. Venous claudication usually occurs when the iliac vein stenosis, doesn't occur in varicose veins. It's a bursting pain, usually occurs in the evening where the leg is already swollen from an entire day's congestion. So these have to be differentiated. When you examine arterial system, you got to examine every system: neurological, eyes, respiratory, cardiac, renal, abdominal, for intestinal, upper limb. Because there's no localized vascular disease. You see a lot of them saying that the localized vascular disease doesn't happen. Diffuse atherosclerosis is common. Everybody has atherosclerosis everywhere. You have it. So vascular exam has to be global. Every system has to be examined. Now, risk factors, you're well aware. The list is there. Commonest of obviously diabetes mellitus and tobacco consumption. In India, hypertension, dyslipidemias do cause problems. And the other spectrum, collagen diseases, are very uncommon. Now, the critical exam is pretty simple. It shouldn't take more than 5 minutes. There's little cold, not always coldness. There's pallor, rubor, pallor, and then we put the foot up. Indians is difficult to see if you're dark color. The leg is elevated because pain, and you put it down, it becomes ruberous, reddish. That's pretty significant of advanced ischemia. Skin mottling, hair loss is the first one. If somebody has a good hair on the toes, very unlikely they have chronic limb-threatening ischemia because hair goes first. Atrophy, brittle skin, tissue loss alteration obvious. Slow capillary filling, difficult to judge a lot of times. Skin atrophy, erythema cellulitis are not common. And edema, swollen leg, is not a feature of peripheral arterial disease. Because swollen leg comes venous disease. When you have peripheral arterial disease, you might get swollen leg because you sit with your foot hanging down because of pain. So edema is not a feature of arterial disease. Every pulse has to be felt. Carotid subclavian, axillary, dorsal pedis, even peroneal, posterolateral. And you need to grade the pulse properly. 0, not palpable. 1 is weak. 2 is normal. 3 is prominent. So this is subjective. Each person can have a little different, but this is a general rule of thumb. When you say 2 is, you mean normal. 2 plus. And you need to listen to Brovies and carotid subclavians and interscapular area, or the abdomen, and the femorals. Now, let's say this patient. That's the assessment. Now, this is a 45-year-old male smoker, diabetes mellitus since 5 years. No other symptoms. Dry ganglion left toe, you got no infection. Severe rest pain, demarcating. You can see a line of demarcation. Demarcation means the body has already tried to control with a collateral blood supply. Everybody has collaterals. Okay, he's demarcating, not infected. There's hair loss. You can see no hair on him. Toe is tender, no fearless leg edema. Now, question. Left femoral artery is felt, popliteal is weak, no palpable pulses below, nothing at all. But you do have Doppler signals at posterolateral, weak signals. Systemic exam is normal. And then ABA is 0.4, and toe brachial index is very important in diabetics because the ankle brachial index can be spuriously high. The toe pressure is very measurable in diabetics. So it's low. So he's got critical limb-threatening ischemia. He's got gangrene, he's got no pulses, he's got rest pain, and then his ABA is very low. Now, can you form a complete working diagnosis and stage his disease, and then I have a treatment plan without doing any further tests? Now, 2 questions. Is this Burgers? A lot of people might want to answer yes or no in your own minds. Does he need to amputation first? 2 important questions. I will tell you why. Is this Burgers? No. Why not? It's not Burgers. Once you have any other risk factor except smoking, whether hyperlipidemia, diabetes, hypertension, you cannot call it Burgers. So only risk factor, not a male patient, is 45 years younger with no comorbid condition except smoking is the only risk factor. Otherwise, you cannot call Burgers. They need to amputation first. Very common to do amputation because toe hurts. Imagine the toe is demarcating. It's not healing. If you amputate, you're going to have a bigger wound. How is that going to heal when you create a bigger wound? So toe amputation should be done only if there's sepsis, limited amputation, ready to revascularize in a very short period of time. Now, okay, does it need toe amputation? The answer I already given, no. What happens if you do a toe amputation as a stable guy? You end up something like this. These are real patients. No, you see, it's ischemic, not a drop of blood in this foot. And then they toe amputated, one toe, two toes to keep extending without doing a vascular evaluation. And eventually somebody will end up like this. So don't do a toe amputation unless it's controlled to infection temporarily, and then immediately subject him to vascular evaluation and assessment and revascularization. Now, complete diagnosis of the patient, very easy. Look at it, you know the patient, he's got a clinical limb-threatening ischemia, left victus gangrene. Where the disease, you can know where the disease exactly is. It's a left femoral distal disease because left common femoral pulse is felt, no pulses below the groin. So he's got a fempop occlusive disease. Pathology, atherosclerosis. He's got diabetes. So you got your primary diagnosis by clinical exam, our 15-minute exam. Now, what's the plan of therapy? He needs vascular assessment because he's got limb-threatening ischemia. If you had a claudic end, I would say no further vascular assessment except for Doppler. So he needs vascular assessment for bypass, angioplasty, whatever you want to do. Now further, the standard assessment for all the patients, the CVC, ECG, echo really not really that. No coronary angiogram unless it's got chest symptoms. Unfortunately, too many coronary angiograms done, too many angioplasties done, even the patient doesn't have symptoms. So anything beyond this, no, anybody else, the non-vascular can do a duplex, you can do an AB if you learn how to do it. So you got your complete diagnosis with physical exam and just with the handheld Doppler. Angiogram and all should be done only after a vascular evaluation by a specialist. Otherwise, you should not be doing angiogram just to diagnose. Now, if you really spend 15 minutes examining the patient and talk to them, listen to the story, and feel his pulses, and then see what the status is, systemic exam, then you can really make this downtrend go away, and then you can really improve the diagnosis and limb and life salvage and a lot lesser cost than if the diagnosis is missed. Definitely prevent this, because if you don't do this, they'll end up with a lot of amputations, a lot of life losses, limb losses, so on and so forth. Now, very important to remember, when you have critical limb ischemia, somebody has got no pulses. You got diagnosed, clear the blocks of the limbs. Does it work? Absolutely yes. We are, department, I think we have crossed about 5,000 to 6,000 lower limb revascularizations. Recently, more and more angioplasties. Limb salvage rate remains at about 96% at 3 months. Unfortunately, we don't know what happens. 6 months is about 80%. Follow-up is lost. Our mortality is about 3% after bypass. Mortality 6% when we fail. Obviously, when you fail, you got to go back and do a second procedure or amputate, or do graft thrombectomy or revascularize. So when you fail, your mortality morbidity goes to 3%, which is not higher than heart is 1.6%. It's about 3%. Now, there's something new that's come out. I talked about vascular disease. This COVID toes. I don't know how many of you heard of this toes. This is not really published literature. This came from not in a journal. COVID toes are probably from small cell thrombosis in the toes, even the fingers. They purplish the hard nodular lesions that come in feet and hands. And they're preempted sometimes, presence of COVID, before they have pulmonary symptoms. I think even in Boston, I think about 5% of patients came with COVID toes. They didn't know COVID toes. They were looking at it. Then afterwards, they came back with COVID, and people had toe amputations. They found there's a thrombosis in small vessels. So you better be aware, not that every pink purplish toe is COVID. COVID toes may appear before without syndrome. Very important. We're going to see that in future in India because it might be neglected. Even the carriers, some carriers, so-called asymptomatic pulmonary carriers were known to have COVID. Again, a small number. So you can't just say this is the norm. It's not the norm by any means. Now, this is what the COVID toes looks like. See, he doesn't have ischemia. See the hair there? So it's not ischemic. It's got a good hair. And these are purplish lesions. I don't know what this patient's outcome was. This is just a picked up from a picture from somewhere. I don't know the details of this, but if you look at two data that comes from Harvard, from Boston, and California, there are quite a few of these, and all the toes they are amputated, rarely go into amputation. They showed small vessel disease with excellent pulses. So you need to be aware of it. I think that's what I'm going to say, and that's the end of my talk. Hope I'm able to convey the importance of peripheral artery disease, how to examine what implies and the impact. And then you're going to see some changes in future. So I thank this opportunity to talk with you. Hope I'm a bit clear. I've been told I speak too fast with a bad accent sometimes. Hope I'm able to convey the message and tell you what exactly peripheral artery disease is. Thank you, Rajesh.
Thanks a lot, sir. That was a very, very good presentation and very good overview of peripheral vascular disease in relation to patients with diabetic foot. I think, shall we go to the question answer session, sir? I have a number of questions. One question is, see, the ankle brachial index is 1.3 and there is an ulcer in the toe. What do you do? Will you say he is peripheral vascular disease?
Very good question. I presume you don't have palpable pulses. Don't forget that. Very important, you feel the pulses. If you've got a palpable pulse, DP and unlikely, you've got peripheral vascular disease. So clinical exam first. If you can't feel them, the ABI of 1.3 shows is a hardening after systemic atherosclerosis. Even if you got a palpable pulses, and assume that toe has not healed for 2 weeks. Minimum is requirement 2 weeks of non-healing ulcer before you consider ischemia. And then if 1.3, you got no pulses, I would work him out. Definitely 1.3 and above, you got non-healing ulcer for 2 weeks. Clean or gangrene, I would definitely work him. Right at 1.3 if you got no pulses. Got a good pulses? No, treat him conservatively.
One question not related to PVD. Dr. Mandal from Jharkhand has asked, is control of diabetes a must before debridement?
For debridement or before revascularization?
Debridement.
That's nearly impossible to do.
I think you can answer for both actually, debridement as well as revascularization.
Control of diabetics for an infected foot? No. Revascularization? No. In India, I'm talking from Indian perspective. They come to us so infected, Rajesh, you can also answer this later on. There's no way of waiting on these patients. Which comes first, horse or the cart? The diabetes, blood sugar is high, 400. On got foot infection, which put it up first? I would say unless you drain the abscess, you're not going to go away. I would not hesitate to drain. Revascularization, yes, you high blood. Ideally, you should do with the blood control. When you commit a wound, ulcer, you don't have time. Theoretically, you don't want to do it because you're already dehydrated because hyperglycemia. You would hydrate them, debride them. Vascular disease, we repair within 2-3 days. Debride, if it's infected, repair within 2-3 days. Arterial repair.
Yes, right. I think I will also agree with you, sir. Removing the infection is very important. If you want to control the blood sugar, you need to remove the infection.
Yep.
Only then I think the blood sugar also is going to come down. Another question, when to decide you would want to ampute rather than going for any revascularization?
Okay.
What makes you decide on a primary amputation rather than going for a?
Obviously, if the gangrene is extended to the ankle or beyond the midfoot, even if revascularization you won't have a usable foot. Usable foot. Even if you do a beautiful procedure, the mid-tarsal amputation, no. The heel is good, midfoot is good, toes are gone, revascularize. Gone beyond the ankle, obviously, no, don't revascularize. Or life expectancy less than 6 months, prefer not to revascularize unless the patient says, I want it done, because I want to walk. And then you do an angiogram, non-reconstructible. Very few are. I need to control only 2% are non-reconstructible with gangrene. Remember that. If you're non-reconstructive disease, whether with angioplasty or hybrid therapy, where you do bypass and angioplasty or purely bypass, yes, I would reconstruct. Functional foot salvage in somebody who's got a decent life expectancy.
Yes, sir. I think functional limb salvage is the term. You have to look for a functional limb salvage. If the patient is expected to walk after a revascularization, you can go ahead
Oh,
and
one
try.
addition.
Yeah.
Sorry, one addition. Somebody who was not ambulating before,
Yeah.
who was not ambulated for 30 days, not because of this. That's a no-no for revascular, because they're going to walk anyway.
Okay. Another question, sir. When do you suspect vasculitis? What will be the workup? How will you differentiate this from a chronic venous ulcer? When do you suspect that it's a vasculitic ulcer?
Vascular lesions are usually occur in very small vessels. They do not cause PAD. As general rule, there are exceptions. I won't go into that. That's too detailed. They do not cause PAD, as we talked about. The small vessel diseases, they have underlying factor, rheumatoid arthritis, renal failure, renal dysfunction. Okay, so PAD and vasculitis are very different. Vasculitis doesn't cause really a gangrene like normal thing. It's a very, very small number. So it doesn't cause PAD at all, vasculitis. What is the other part of the question, Rajesh?
What will be the workup for vasculitis?
Okay. Now we have somebody who's in our department. We also have a immunologist. We have them do the workup. And then all this workup is ANCA, CANCA, and other things, rheumatoid factor, they all need to be done. Remember, chronic venous ulcer, that's somebody asked about venous ulcer. If you have chronic venous disease, they can have a vasculitis component because chronic ulcers can lead to vasculitis-like syndromes. So you need to correct the venous disease and have maybe a short burst of immunotherapy or pulse therapies to heal the ulcer. Combine. This thing is best to have a rheumatologist or immunologist work with you.
And how do you differentiate it from a chronic venous ulcer?
Oh, chronic venous ulcer is in the gaiter area. Almost always in the gaiter, which is around the ankle. Gaiter is where they used to put the around the ankle of the horses so that they won't cut the leg off. So that's where the ulcer comes. You don't get venous ulcer anywhere else. Vascular ulcers are rarely occur in that area. Almost in the toes, somewhere else, the multiples. Venous ulcers are usually single on both sides. And obviously for venous ulcer, when you have big venous ulcer, there is a venous pathology. You have varicose veins, have a big venous ulcer, a common femoral vein occlusion, which means angioma. So vascular ulcer multiple distribution, they're much more superficial. So you can easily make out. Venous Doppler don't have, remember they can be overlapped. Vascular ulcer very rarely occur in the gaiter area alone. There are other places. And also, don't confuse with the diabetic necrobiasis diabetic orum. That sometimes looks like vasculitis. Small punctate ulcer in the blackened area and uncontrolled diabetes. Necrobiasis, dermal vessel thrombosis. That also looks like vasculitis.
One question from Dr. Praveen from Surat. Does prostaglandin help in critical limb ischemia where arterial surgery and angioplasty are not possible?
Yes, we use it quite extensively. Answer yes or no. Should say yes. These are for no option patients. Now, works very well in Berger's disease, where the pathology, if you stop smoking, they will get better. Berger, they don't smoke, nothing works. So we use it on a monthly basis. Yes, no option patients. And as an adjunct, when you have partial reconstruction of a vascular, and they only if they have ischemia, not for claudication. The ischemia with the forefoot, where the rest of the foot is heel is salvageable. But you have to use in cycles, not one shot for 3 days. We bring them back every month, every 2 weeks, every month. Give them for 3 to 5 days for cycle. Yes, it does help. But the patient selection is very important. I would suspect less than 1% of patients we see get procyclin infusion. Primary.
What is the protocol that you?
We use 500 micrograms divided to 5 days. Okay, each 100 micrograms is given diluted, given over 8 hours for 5 days. Now we cut that down because hospitalization. Okay, it can cause hypotension, tachycardia in some patients, older patients. Here we give 1 hour rest in between and give it all 5 different bottles, diluted in 500 or 500 ml, depending on the patient's fluid load. And ideally give it every day for 5 days in older patients. The minimum that 2-3 cycles, every 2 weeks, every month. It does work, but as an adjunct, not a primary treatment, mostly.
And there is one question from V.K. from Neyveli. I think patient comes with DKA, ketoacidosis, with very bad diabetic foot abscess. Patient is not fit for anesthesia. Medical how safe it is to do IND and debridement under local anesthesia? That is his question, sir.
I think Rajesh can answer this better. Very safe. Remember, if you don't do it, you might lose the patient, not just the leg. Even if you think the leg is going to be lost, okay? You know this guy, you're not going to save his leg. You need to get at the dead tissue, the abscess, so you can control the decay. You don't want to go into a primary amputation of somebody in decay. The foot is not salvageable, let's assume. I don't know how you cannot do a adequate debridement, not a complete debridement, not bedside, ankle block, popliteal block. People are very good. You can do it yourself. Rajesh, you can expand on that answer. I don't see I would leave that patient alone. I would debride him.
Actually, even if the patient is fit for spinal anesthesia or general anesthesia, almost 99% of our patients we do under regional block. So local anesthesia, again, if you have a trained anesthetist, you can always go for even a popliteal block, or you can go for a sciatic or a sciatic block, and femoral block. I think that helps in almost. You can even go for a below-knee or an above-knee amputation. We have done a number of cases just with blocks.
One more point is you have to realize general anesthesia is extraordinarily safe. What's safe in high-risk patients? Unless you have a cardiac event, which you're going to induce, even there is very safe. There's some notion. Problem is social event. If something happens in anesthesia, patient family is going to come after you. Tell him he's under local, everybody is happy. The DKA patient, that much sepsis, is going to be at risk. Whether you do it in a popliteal block or a GA is very safe. Safe for the spinal. Fluid shifts are less with GA in these patients than with epidural spinal. They require less fluid replacements.
This is a question from Dr. VBN Murthy from Chennai.
Hello, VBN.
What is the predictability of a successful angioplasty or amputation if not successful?
Predictability.
Yeah, predictability.
How do you predict what's successful?
Yes,
yeah,
I think so.
Hey, if VBN can hear me, he should be answering that question, not asking me. Anyway, now there's a classification, the risk factor stratification, which has come out to be used quite extensively. First is Wi-Fi. I don't go into that. Wound ischemia classification that predicts the limb loss in these patients. Wound infection, ischemia. We combine with what's called a GLASS, Global Limb Anatomy System. It's a GLASS system that shows that's quite complex. We combine these two to see how predictable this patient is. Not only predictability, which would suit the patient better. That's quite an extensive exercise to go through as a surgeons. So we combine these risk factors. See what can be done for this patient. So Wi-Fi plus GLASS system, what we use.
Dr. Srikanth Boyer from Mumbai, what is your opinion about calcification of a posterior tibial artery in the leg? Does it give you some information whether again there is an ischemic wound in that foot? Does it give you any information? Does it change your management?
No, it doesn't. Actually, it doesn't change. Good question. Because calcific arteries means, we see a lot of calcific arteries in India. Calcification means mostly renal dysfunction patient. That's a very high. Middle calcinosis. Calcification does not preclude you from doing an angioplasty. Calcification also does not show you the patient has ischemia. So it depends on imaging. When you have calcification patients, MRI gives you very good imaging. Okay? CT doesn't below the knee because it's so much calcium you can't make out. So you need a luminogram. You've got a wound. I'm talking about critical limb ischemia, somebody with a wound or a gangrene, not cardiac. Calcification itself does not preclude or does not tell you the patient has advanced disease or nothing can be done, cannot be
done. I think number of textbooks say, I think, rather than a CT arteriogram, better will be a MR angiogram. Again, what is your experience here in the Indian context? Again, even MR, you have both contrast and non-contrast MR angiograms. What is your take on that?
Yeah, good question. When we want a proximal vessels, aorta, up to femoral, maybe even up to popliteal, CT is excellent, especially with aneurysms and abdominal aorta and iliacs. CT gives excellent spatial resolution. As you come down, the resolution is lost because of heavy calcium. Especially even in India, even a non-diabetic patient with calcium. So you end up losing it. Okay. Can you hear me?
Yes, sir. Yes, sir. Very well, sir.
Look at power. So I would do an MR if you're suspecting for a diabetic foot with the normal femoral vessels. If you don't have femoral vessels, we go for a CT. We do mostly MR because our disease is mostly lymphopoverty. Number two, when renal failure patient, if you've got a good radiologist, you give excellent top image, time of flight images. Is as good a luminogram as an angiogram. Almost, not equal to angiogram. Other option we do in these patients is we do a DSA. As a vascular surgery with carbon dioxide. We don't use a dye. Renal failure patient talking about. So you can do a top or you can do a carbon dioxide angiogram. Would not do a CT, obviously, because of renal dysfunction in this patient. Preference is
tibial angioplasties, again, your carbon dioxide angiogram doesn't, do you get the clarity below popliteal vessels in carbon dioxide?
No, we use it only for below popliteal vessels. We have done aneurysms with that in renal failure patient. It's nowhere as good as regular angiogram. We found out one thing. If you do that, we used to do the mostly at the local. The patient movement is very heavy when you are local because when you inject carbon dioxide, the volume is high. The patient has a pain because of distension of blood vessels. We do it under block or even general, your resolution improves. And we have no hesitation giving a 5 cc of dye. We have done about maybe a couple of hundred of CO2 angiogram. We know that only 10% have required a dye. Otherwise, you can do everything on the CO2.
Will non-contrast MR angiogram be the standard over the years to come, sir, for visualization?
As of now, no. You're talking about tibial vessels?
Yes, sir.
Non-contrast, I'm talking only about tibial vessels, not proximal. It won't be the standard because the resolution is less, but it'll tell you where the disease is. It may not be giving you it both overestimates and underestimates. With a period of time, it might be, but as I see it now, next 1 or 2 years, it's not the standard. And totally dependent on the user. You can have a radiologist who gives you a wonderful picture with the same, like a Doppler. Duplex, I'm sure you're aware of how good a duplex can be. I can do only with a duplex.
User dependent.
So it depends on user. Right now, it's not the standard. It won't be for a year or two, in my opinion.
Dr. Iswaran, Tangavelu Iswaran from Erode, what is the role of silestazole? I think prostaglandins you have answered. Silestazole in CLI. Another related question is on pentoxifylline.
Yeah, both are not used for CLI. CLI has no role. We use it on a post-reconstruction. Silestazole, outstanding drug for claudication. Outstanding drug. 80% response. Problem of silestazole is 20% cannot take it because of headache or palpitations. Pentoxifylline has proven to be not any better than placebo. But we use it when we don't have anything else. But not for CLI. Remember, CLI has no drug. Your prostacyclin are kind of we'll use it kind of drug, not a primary drug. But claudication, silestazole response is excellent. Only for femoral distal vessels. Aortoiliac disease, silestazole response is very low, about 20% response. Below inguinal femoral artery disease, 80% respond. The claudicators, not critical limb ischemia. Now, silestazole, lot of use post-reconstruction. That itself is a big topic.
I think there is one question from Dr. Amit Ratan from Mandi, Himachal Pradesh. How long will you continue drugs like silestazole? How long will you continue?
Silestazole is continued for 3 months. Okay, claudication again. We're talking about claudicators, 3 months. The response is good. We usually start at 50 BID, which is not the right dose, to make sure you don't get headache palpitate. Then correct dose 100 BID for minimum 3 months. bring the patient back in 3 weeks because you will not see a response next day. If you're going to improve the claudication, of course, walking goes with it. 3 weeks, minimum 3 months. You can continue. Some people, when you take off silostazole, they get claudication. For them, you continue forever. There's no really long-term side effects of silostazole.
But I think you need to be careful about cardiac failure with silostazole. Sir.
That's only if you, good point. This is if you have somebody with cardiac failure in certain patients, CHF, as a group of things, they will cause problems. But you're right, we do not use that patient as CHF.
Another question, sir. What is the treatment protocol for atherosclerotic gangrene of toes?
Atherosclerotic gangrene of the toe. I think that's what I talked about. I was presuming it's got tibial disease or something. Go to angioplasty, amputation if it's infected. If not, reconstruct the blood vessel, see where the lesion is. You don't get atherosclerosis of the toe. You get atherosclerosis tibial vessel. Actually, they're spared quite a bit, in fact. That's why you get a toe pressure, which is more accurate than ankle pressure, even in diabetics.
Dr. Rajiv Kumar Singh from Mumbai, he says again he has a patient with monophasic monophasic tibial vessels. Ejection fraction is around 15%. Can we consider this patient for revascularization?
Why is it 1.5? Ejection fraction 1.5? Monophasic doesn't mean he has revascularized. Does he have gangrene, tissue loss, respite? Yes. 15%? Yes. If he's going to think he's going to lose the leg, we still do it. We do an angioplasty and local. Monophasic flow doesn't mean anything. That shows there's a proximal disease. It doesn't tell you symptoms. If it does bad symptoms, gangrene, tissue loss, we would do. And a local.
One question from Dr. Ramesh from Hubli. What is your approach in a patient with DFU, diabetic foot ulcer, and a Doppler showing biphasic flow in PTA, posterior tibial artery? Would you want to do anything for that?
No. If the posterior antitibial is felt, ABA, TBA normal, no. Again, if they're not felt, then yes, 2 weeks is not healed. Even if ABA is, let's say, before the ABA, critical ABA is 0.5. With Wi-Fi classification, doesn't matter. Even if it's 0.7, the diabetic ulcer, not healing. That's why it's chronic limb-threatening ischemia. It doesn't heal in 2 weeks or 50% decrease in 2 weeks. We'll work him up and then correct it.
Your experience...
Remember, one pulse is enough to heal a wound. You don't need both. Anterior, posterior, peroneal. It's open, most of them heal the wound.
A related question, sir. Sometimes, do you come across patients with palpable pulses and ischemia of the ischemic gangrene in the toes?
Yeah, we see about 10 a month. Now, that means it's an embolic lesion. It's called a thrash foot. Or I want a better name is a blue toe or thrash foot.
Blue toe syndrome.
Like before, you used to see from heart emboli. Proximal lesion, got a good pulse, but the toes are gangrenous. Nearly always it means there's a lesion, maybe an aneurysm sometimes, or a atherosclerotic lesion which is embolizing the city, like a TIA in a carotid. A similar TIA in a carotid, if they have blue toes and a lesion, that lesion needs to be corrected proximally. Again, need an angiogram for the patient.
What other tests would you do, sir, in addition to an angiogram for this patient?
This patient definitely would do an angiogram.
No. Okay.
Somebody with a so-called blue toe syndrome, with a palpable pulse but ischemic toes and palpable pulses, I would do an angiogram. Doppler is not very good in picking that in this case. MR is fine.
And then echo also maybe to rule out any atrial thrombi.
Echo, now it's become so rare. We do an echo on all our patients. It's never been indicated of doing in vascular patients. It's just to the patient's family, you got a bad heart. It means nothing to us. Echo has never been a workup for a vascular disease. Now, how often you see rheumatic heart disease? Now you see more when you see from the heart, the big thrombus. If you got a disconnected segment, if they're thrombus, they're not atheroemboli. And the carotid and the popliteal lesion, femoral lesion. We do it, but even if they have it, then I would still look at the lower limb blood vessels.
Is there a role for tolazolin in diagnosis of microvascular disease in the foot?
For what? For hydrovascular.
Tolazolin,
You know
Tolazolin,
that?
tolazolin.
Yeah. That used to be to induce ischemia, serious lesion before. Not used anymore. If you call it, see, if you don't have a questionable lesion, you vasodilate sometimes. See, there's ischemia. There's no role for that.
Your take on microvascular disease of the foot, sir?
Microvascular disease exists. It's not like other places. Microvascular disease just means thickening the basement membrane, nothing else. It is not a contraindication for a revascularization. Really causes very little trouble. Microvascular disease mostly in vasonervorum, neuropathy. That's one of the causes. You can expand on it. Now, we do not look at it as a cause for a major ischemia in the foot and reconstruct. One second. Sorry. Now, there's a very good Italian study which shows somebody who's got a foot abscess, not drained for a long time. They thrombo the small vessels. Somebody transplant was amputated. Forgot the guy's name. He'd come to India for DFSI. Can't remember his name. Bangalore. When you leave the foot has a very tight compartment, 3 tight compartments. If you don't drain, foot and the brain have very tight compartments. If you leave the abscess for a long time, that itself causes thrombosis of small vessels. I mean to reconstruct veins, arteries, arterioles. It's important to remember, drain them early so that you don't get like compartment-like syndrome, which is very unyielding after revascularization.
Septic emboli. Another related question, sir. A patient has a heel ulcer, ischemic ulcer, and he has underwent a revascularization. When will you plan for reconstruction of this after a revascularization? How long will you wait before you proceed with reconstruction?
Very good question. Assume we have a successful revascularization, preferably angiosome concept. That means posterior tibial feeds that. We got posterior tibial. And we put a vacuum. As soon as the wound looks healthy, we stop culturing because I don't see getting negative cultures at all in India virtually. When the wound looks healthy, ready, 2 weeks, 3 weeks, sometimes longer than that. There's no specific time limit on that. When the wound looks healthy and clean, I would do them sooner because remember, lower limb angioplasty is not sustainable for like coronals. They will occlude in 3 to 6 months. So you want to heal the ulcer before that. The outcome is limb salvage, not patency. So I would skin graft them or do whatever you want to sooner than later as soon as the wound is clean.
But again, if the wound is clean, sir, say for example, the patient has underwent a partial calcanectomy, would maybe planning for a reverse sural flap and all. After an angioplasty, would you do it the next week itself? Would you want to do it in the same admission itself, or would you want to wait for some more time?
No. The angioplasty, I would wait longer because you are damaging the artery. Angioplasty is just a brute force of a balloon. We are causing it. So the remodeling takes 2 to 3 weeks minimum. Just like a scar, remodeling of angioplasty segment takes 2 to 3 weeks. Ideally wait for that even longer if you can. It's only a skin graft is fine. If you're going to put a flap based on all the blood vessel plasty, you should wait.
Does TCPO2 or any other investigation help you in determining the final success of a procedure?
We do TCPO2 on all the patients. Every patient gets it, TCPO2. But the predictability is low. Both sensitivity and specificity of TCPO2 for ischemic patients is low. And we have to do a lot of in good temperature, wait for some time. So we use it, but that would not be a determinant to revascularize, not to revascularize. One thing about TCPO2 is if you're flat and you hang down your foot, measure TCPO2, if it goes by 10 to 15, your success rates are much better. So that's again is not a study related, that's observation. When you put your foot up, foot down and measure TCPO2, it goes up by 10. Possibly, below 20 TCPO2, the healing is very high, very low rather. If you get about 30 or 40, your healing will be very good.
I think one question from Dr. Hemil from Surat. Importance of TBI, toe brachial index, in patients with diabetes for non-compressible vessels. So your take on that, sir?
Yeah, very important. We do TBI in all the patients. The problem in India is about a third or fourth of our patients don't have toes. They come with the gang, you can do TBI. Unfortunately, I've done a transplant. A lot more common see toe gangrene than heel gangrene, which is good in a way. TBI is very important because ABI, maybe in a third of diabetes or more, is not accurate. So TBI is important, but does not dictate your that's for follow-up. See what the baseline is, what you do for follow-up. Does not dictate whether you do something or not.
Your take on renal foot with PVD. Your take on that, sir? Patient with chronic renal disease and PVD.
Yeah. When you say, assuming that you're going to go reconstruct, your results, you drop by 10-15% automatic. Not on dialysis. Somebody has renal dysfunction. Remember, 1.6 creatinine is not normal because renal compensation is so heavy. When you have renal dysfunction, you know your result is going to drop by at least 10%. We need to tell the patient. That means not that we don't do it. And there is definitely increased renal dysfunction with the use of dye in these patients. So when you get a CKD of any, especially if you have below 60, if you do EGFR below 60, you know your results are going to drop, healing drops by about at least under 10-15%. But we still would do them, wouldn't sacrifice them.
Role of hyperbaric oxygen therapy in healing an ischemic wound, sir?
I would say none. Now, hyperbaric oxygen, excellent adjunct. Adjunct, if you look at data from the US, the hyperbaric oxygen and therapy, the requirement of hyperbaric oxygen is they had a 1 month in a non-ischemic wound, 1 month of proper treatment without decrease to give hyperbaric oxygen. Or in ischemic wound, revascularization, debridement, then hyperbaric oxygen. Not a primary treatment. Secondary adjunct for a non-healing wound, like arterial sensitive, there pumps available. I would not use the primary. Again, like prostaglandin, it's a no option patient you can try. There's no data to show that it heals the ischemic wound.
Your take on this arterial pumps which are available now?
Yeah, we use it a lot. Very questionable device. We use it when you're partial reconstructive, you cannot do full reconstruction. It does improve the collateralization on infrapopliteal vessels only. I wouldn't do it for femoral. Infrapopliteal vessels, you can reconstruct, yes, but the reported success rate varies from 30 to 70%. So take a call. That's so huge, which means you're not sure. In such a way, we use it, but on limited patients for partial.
How long will you try that?
We use for 4 to 6 weeks.
4 to 6 weeks.
Yeah. The problem is they have to come 4 times a week minimum. Cost factor comes in. 4 times a week. So we had to be somebody in Bangalore 4 or 5 times a week. Then 4 or 5 weeks. That becomes a problem. Logistic problem.
Maybe the rental model would work there, I think.
Rental model will be difficult because they need to put it properly. Rental model will work. We're not tried it. Because see, when these patients, when you use arterial assist device, you need to see them at least once a week. You need to see the wound. You're not going to do it without critical ischemia. See, rental model, they stay home for 3 weeks and come back with the bag. What's looking for?
One question from Anya from Chennai. Using tacrolimus ointment along with applying 2-layer compression bandage, will it help in a vasculitic ulcer?
I don't know the answer to that, actually. You can answer. I don't know vasculitic ulcer, anything helps. See, you can put anything on the wound. There's no specific treatment. Like Andrew Bolton said, any ulcer in the wound, put anything except patient's weight. So offload the patient if it's in the wrong place. I don't think there's any specific ointment which has a magic to heal. Systemic therapy, good vascularization, good care, debridement. Unless, you can add something, if you want. Rajesh, you can add something to that. They really don't use much healing.
It's one of the most difficult wounds to manage, vasculitic ulcers. We have had a decent this thing with me again after treating for infection and looking for vascular these things. We have had good results with tacrolimus ointments. The local inflammation gets suppressed, and to some extent, patients are a little okay with that. So.
Okay.
Dr. Mohan Patro from Visakhapatnam. Definitive segmental block with good collaterals. What is the management?
Definitive
segmental block. I am unable to understand.
Segmental block where?
With good collaterals. Probably, maybe I think.
Okay. Let me understand. Say, done good. Everybody has collaterals. You don't have collateral, foot is gone. So again, clinically indicated. Doesn't matter what collaterals we have. Clinically, patient getting ischemic. Yes, good or bad collaterals, you correct them. Obviously, collateral not working enough to heal the wound. Remember, we don't have a wound, it's fine. Doesn't matter what block. Demand is very high to heal a wound. 40 to 60% increased blood supply is required. Maybe the segmental block is not able to increase, or the collateral not able to increase the healing of the wound. Non-healing wound doesn't matter how much the block, short block, long block, to need to correct.
Question on role of rivaroxaban and other anticoagulants in patients where you cannot do a corrective procedure, and in those who have underwent corrective procedure as a preventive measure for recurrent ulcerations.
Right. Primary, there's no role as a primary treatment, any anticoagulation. You're talking about critical ischemia, not thrombotic occlusion, assume.
Yes, sir. Yeah.
So there's no role at all for any anticoagulation, unless you want to prevent DVT and other things. For arterial, primary treatment, no. Now, after intervention, there are certain indications to use anticoagulation. You use anticoagulation only while in the hospital. You use a vein graft, use anticoagulation. Otherwise, no role for anticoagulation. Not thrombectomy. But now there's a lot of data, there's one called COMPASS trial. The use of rivaroxaban in these patients is not for the leg alone. Because this, to prevent, even use a 2.5 milligrams, then there's a decreased event in future, even in stable patients. Future systemic cardiovascular events. Take any color, heart, brain, leg. So today, maybe 2.5 milligrams should be common for all the patients, apart from statins and antiplatelets, of course. And 2.5 doesn't include bleeding. Maybe that should be the norm in treatment in this patient. Not purely for reconstruction, not as a primary treatment.
But COMPASS trial, it is 2.5 BD, no, sir? That,
yeah. Now, there's one more called Voyager trial. Just come out. Just come out. Yes, that's 2.5, small dose. We had done a study with 10 mg. The bleeding does seem to be high, but in our number of patients only about 150. All reconstructed patients. That's a different group.
There is a question on, in case of an isolated ATA or PTA occlusion, what do you suggest? Do you want to intervene?
No, foot is normal, don't intervene. Foot is abnormal, intervene. Remember, they could have only one vessel, ATA, others are blocked. Back to clinical indication. Please don't think about doing anything unless patient has a ischemic wound. Ischemic wound, yes. We have ATA, PT, even the arch. You can recanalize the arch, present day. You can do retrograde approach. Go from the dorsalis fetus, go up, and come down from above, go both ways. Bottom line, you need to go clinically. If clinically indicated, yes, I would do that.
What is the optimal antiplatelet regimen for diabetic patients with and without claudication? Dr. V.S. Arthi from Chennai.
Okay. Claudication, the antiplatelet is for coronary stroke, not for the leg. It does nothing to the leg. Because these patients might have an MI in future. You go at aspirin 75 mg or clopidogrel, similar to what is the coronary event, what is the cardiology event. But if you do intervention for CLI, then you need to dual antiplatelets for at least 30 days. I'm talking about angioplasty. And then after single antiplatelet is aspirin. That's the regimen. But the regimen used for claudication is to prevent systemic problems, not to improve the claudication. It has no effect on the claudication, but decrease the MI and stroke, including statins, of course.
What is the role of lumbar sympathectomy. Dr. Rajan Relekar from Thane wants to know role of lumbar sympathectomy.
Very rarely used. Lumbar sympathectomy in diabetic patients is known not to work because they already have neuropathy. So you're not going to make it better. Burgers disease patients and in any other vasospastic disorder, which is uncommon, there's a definite role if there's an ulcer, not for claudication. Now, with Prostatin, we have already virtually stopped doing lumbar sympathectomy. That's only in Burgers patients, where there is severe vasospastic component, not in diabetic patients.
I think we have a lot more questions, sir. I think we have almost reached the end of our session. I think it's almost 7:30 now. So I would like to thank you for this wonderful presentation. And I would like to thank all our audience for being patient and again bringing up a lot of questions. And I think we had a very, very good discussion part also, in addition to an excellent presentation, sir, by you. And before leaving, I think I would want to welcome all of you to attend our third webinar from Diabetic Society of India. That is going to be on 6th of June. That is next Saturday between 6 to 7 p.m. Dr. V.B. Narayanamurthy, who is our Vice President of DFSI and a Senior Consultant at Kaveri Hospitals and at High Care Super Specialty Hospitals. I think he is going to make a presentation on wound healing and DFU. And Dr. Sunil Kari will be the moderator for this session. Once again, I would like to thank Dr. Suresh and the audience and Sun Pharma for making this happen. Thanks a lot, sir.
Thank you all. Thanks for the wonderful questions and interaction. Thank you. Enjoyed it.
Thank you, sir. Thank you, sir.
Bye.
Bye, sir.